Well, hello everyone. My name is Garrett Schmidt, and I'm the CEO and Managing Editor of VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by Roji Health Intelligence. And today is a part one of a multi-part series called Achieving Growth and Prosperity for Specialists under Risk Payment Models. And today we're talking about TEAM, which is the Transforming Episode Accountability Model. And I know there's been a lot of buzz surrounding this. And there's a lot to cover today, so we'll get to it in just a moment. A couple of housekeeping items today. Everyone has joined today rather in listen-only mode. So this is a traditional webinar format. So you don't need to turn off your camera or your microphone. We can't see you or hear you. However, we do want to hear from you, and we are going to have a time for some Q&A towards the end of the presentation. If you have a question at any point, you don't need to wait until the Q&A to ask it. You can actually use your control module. There's a place specifically for questions. And so go ahead and drop your question there. We're going to get to as many as we can. We have a lot to cover today, so it may be that we don't have a ton of time for questions, but don't worry, someone will make sure to get back to you to answer that question. Also, this session today is being recorded, so and you'll be glad that it is, again, because it's going to be very dense, and so you'll get a chance to review it at your leisure and share it with colleagues and friends, and we hope that you do. So when we conclude, we're going to send out a link to where you can watch the recording and access the recording, as well as download the slides from today's session, and we hope that you do that. So without further ado, let me very briefly introduce Miss Teresa Hush, and she is the CEO and co-founder of Roji Health Intelligence. And I'll turn it over to you at this time, Terry. Welcome.
Thank you, Garrett. It's exciting to be here today. And I think you might have scared everybody by saying this is really dense a couple times, but I guess I told you this is a very intense
In a
topic.
good way, in a good way. It's rich.
In
Let's
a
use
good
that
way,
word.
in a good,
Yeah.
very good way. What we're going to get into for the first time, really in depth, are specialty payment models. And this is where a lot of the interest and the direction is going to be over the next several years. So I think TEAM is an exciting one. It's one that's starting now, and the participants are chosen, and it is mandatory. So without further intro, let me get into what we're going to talk about today. So, and why should I be talking to you about it? Well, the most important thing is the last point on this slide, which is we have the technology and the measures that are used for evaluating progress under these kinds of payment models. So take a look, go to our website, that'll come up at the end of the broadcast here. So let's talk a little bit about TEAM. Now, I'm not going to go into great detail here because you can find all of this information on the cms.gov website and a lot more. So feel free to take a look there. But the most important features here is that this is a mandatory 5-year two-sided risk model, meaning providers are at risk and there's not an option about that. The goals are on the blue part of this slide, quicker recovery after surgery. It's a surgically focused payment model. It's only about the episode related to particular surgeries. Another goal is fewer avoidable hospital visits and emergency room visits, shorter stays, smoother transition back to primaries, which is a new element that's working its way into specialty payment models, and lower costs, of course, which we know that's the goal. CMS is telling that with every single payment model now. The TEAM episode categories, or the surgeries that are involved, are CABG, major bowel, several procedures in that group, and then joint replacements on the lower side, lower extremity joint replacements, and surgical hip and femur fracture treatment and spinal fusion. So 2 orthopedic groups, 1 neurosurgery / orthopedic, and then GI and cardiovascular surgery. So let me find out a little bit about who the audience is who's looking at this presentation now, and so I can gear my remarks to that. If you are a Wide-mouthed little cat, you are a participant and you are in the early end of that learning process, number one. Or you may be a participant and you're well versed in this and you're ready to go. Or you're not a participant, but you know what's coming down the line is going to hit more procedures, and so you want to learn. Garrett, you're going to run the
All
poll.
right, I am running it right now. So you should see on your screen a poll here, and this is anonymous, by the way. We're gonna have a couple of these so you can play along at home. And this one is, what is your background with team? Are you a participant in learning, like that little cat? Are you a participant and ready for action, like the tiger? Or are you not a participant and you want to see what's coming? You're just kind of observing from a distance, which is totally fine. There's a lot to learn here. Are you like that little fox? So we're going to give it another maybe 5 seconds for folks to vote here, and we'll show the results, by the way. And this is anonymous. This is kind of just more for fun. So we'll close it down in 3, 2, and 1. And I think most of people have voted at this point. Okay, so Terry, we have 34% of the audience is participant in learning. 17% are participating in ready for action now,
Great.
and 48% of you are not participating and just wanting to see what's coming.
That's good. That's good to know because I don't see this model being very static. I'm sure that we will see other procedures on this list in the future. So let's move to what's important about team. Well, number one, it's big. There's over 700 hospitals involved in this, and all of the physicians and patients associated with these particular surgeries. Secondly, this is a really clinically important list of procedures. So the highest volume and the highest or the highest cost procedures in the entire Medicare program. So they are very, very important clinically to the organizations who are allowing them to happen on their premises and to the physicians that are doing it and to the patients. It's a They are the top of the line, as you would expect, in the first effort to look at surgical costs. Third, and I think this is a significant feature of the model itself, there's a very targeted time frame, and I mean the episode time frame, the procedure plus 30 days after. That's very, very focused, and a lot happens in that period. So we're going to look at the ramifications of this. Fourth, the hospital is at risk. Even though the physicians are performing the services, the patient chose the physician, the hospital appears to be kind of on the periphery of that. It's the facility where this is happening. But this changes the dynamic between hospitals and physicians, and we'll get into that. That's an important feature about team. But all providers who were involved in the episode were included. So it's not just the surgeon who's involved. There's no trigger surgeon, or there is a trigger surgeon, but it's not the only provider involved. The anesthesiologist is involved, and anybody else who is on that clinical team will be involved in this. There's a coordination requirement with the PCP. This first showed up in the new ASM model, and now it was worked back into the rule in this model as well. And then finally, it's a mandatory. You don't get to say you don't want to participate in team no matter what kind of hospital you are. You may have a different risk level depending on your hospital type status, but it will be mandatory for everybody who's been selected. So pulling out of that, the key concept I want to focus on is that the hospital risk and the all provider inclusion creates a different kind of accountability going on in team, which really forces collaboration between the hospital and the physicians. The hospitals have historically looked at physicians as more of a revenue partner, but now they have to engage on what's happening in the OR to avoid downside risk. And that collaboration agreement that's part of team is going to be a very important concept. Even though there's not specifically recognition for physicians in team as part of the revenue or risk part of this. There is an opportunity for physicians to generate growth and revenue out of team. And why is that? Well, because it improves their process. There will be public reporting here. The hospitals can't reduce complications alone, so it will have to be a partnership in order for this to really be effective. And physicians who are a good team and provide better opportunities for the hospital and the other physicians will be a better and more sought after partner, not just in CMS, but in other opportunities as well. And we see those opportunities coming through the private market as well. I'm going to go into a little bit of the model itself in terms of the pricing and risk, but honestly, you should be looking on the CMS material for a lot of this. I just want to cover it in broad detail because what I want to talk about is how you make this work, and we'll get into that next. CMS is going to calculate the target prices in advance based on historical spending. The hospitals will continue to build the DRGs. The individual episodes will begin at the anchor procedure. There's no look back. There's nothing that happens or is captured prior to the trigger procedure. And the episodes will include most Part A and Part B charges, including all of the physician charges. And the end of year reconciliation results will result in shared savings or losses from that line of cost that CMS sets. There will be 3 risk tracks. The year 1 is basically an upside only risk, and you can choose whether you want to be in only upside, or if you're ready to go, if you're the tiger, you might want to go into a 2-sided risk arrangement from the get-go. But you have the practice opportunity at your choice. Year 2 is, or track 2 is a 2-sided risk with a stop loss gain, and year 3 is a 2-sided risk. Now, safety net hospitals will not have risk throughout this period, so it will be a completely different environment for safety net hospitals. But it will be judged independently, so that will be a CMS determination of whether they fit those kind of criteria to get into and stay in a non-risk environment. There are quality measures that are linked to payment too. There's all-cause readmission, which is an important one, and that is probably the one that is going to be the highest issue in terms of cost. There are specific measures, for example, on the knee replacements and hip replacements. There's a patient-reported outcome performance measure. There's an adverse events composite measure for everyone. There's a false measure, post-op respiratory failure related to anesthesia, and then a 3rd-day risk. So what I want to hear from you is what you think the biggest concern for your organization is about team. Whether or not you're participating or you see this as something that you might have to participate in the future. Is it financial impact? Is it the teamwork aspect of the hospitals and physicians working together to resolve cost and quality issues? Or it's what CMS does with the data in the future? Which one of these is going to be your biggest concern?
All right, and once again, this should be up on your screen. So what is your biggest concern about team? Financial, teamwork to resolve the cost and quality, or what CMS does with the data in the future, which is a valid concern. And
Look
these
at that
may all
picture.
be
Kind
issues.
of dark and it looks kind of dark and bleak, right?
Yeah. So these may all be valid concerns, but if you had to pick one that would be of most concern, how would you rate that one? So we're going to give this another maybe 10 seconds and then we'll close it down. your biggest concern about team. And if you're joining us later here, we're going to have, I think, one more of these later on in the session, and these are anonymous, so feel free to participate. Okay, I think all the results are in. I'm going to go ahead and share the results. Okay, so Terry, we've got 38% said financial impact, 48% said teamwork to resolve costs and quality issues, and 14% are worried about what CMS does with the data in the future.
Oh, very interesting. Well, I guess having worked in an academic medical center, maybe a lot of people in, the politics of working to resolve cost and quality issues are a big thing. But the model is designed so that some people are above the line and some people are below the line of that target. So the financial impact is unmistakable. It will happen to a huge portion of the participants. So an interesting result. So let's talk about the real meat of this presentation, which is what are the episodes about and what are the opportunities within those episodes to save money and to establish those kinds of teamwork initiatives. So again, the episode timeline is key. It's a procedure and 30 days after, just about everything is in there. And then there's post-procedure costs up to 30 days. So those could include SNF, it could include rehab or home services, or it can include all the complications that happen. CMS chose that time frame because most of the complications and the big costs happen within that 30-day window. So they want to capture the big things that are going on. Here's the outlay of costs. There's not a whole lot that's excluded. There are some drugs, very high cost drugs, that are excluded from the episodes, but just about everything else is in. Now, this is something that I think really shows what's going on in the episode. And that is kind of a diagram that I thought, well, how can I display that what's really creating the middle part of that high cost phase is partly what's happening before. So you have a patient walking across the horizon there, which is the timeline of the episode. The patient has diabetes right away going in, then develops breathing issues, fatigue, gets a PCP referral to a cardiologist. The cardiologist does tests. Oh, there's some problems here. Schedules a visit with a cardiovascular surgeon who schedules surgery. And then the day of surgery happens and the patient has problems in surgery. He meets the anesthesiast as he's being wheeled in or ready to go under. The surgery happens. There were a couple complications. First of all, the patient developed AFib after the procedure. And secondly, there was a prolonged period of ventilation, which meant time in the ICU, those two together. Then later, the patient developed a sternal infection, encouraging more services to happen, but also delaying the time of discharge. Then the patient was discharged to a rehab facility where they spent some time, but the patient fell, went back into the hospital, and then while the patient was in the rehab facility, the 30-day period ended. So this is kind of a same old, right? This is a huge number of patients have these issues going in, and a huge number of patients have these issues while they're there. AFib, prolonged ventilation, and sternal infections are the top 3 complications for CABG. So this isn't, pie in the sky, I manufactured it. This is what we're really dealing with. So in the light of that, looking at all these actors and all these different agendas going on here, envisioned by this slide that has nothing to do with the CABG, but hopefully is some some fun. How do providers actually affect the team procedure costs? It's going to involve three things. First, working collegially between the hospital and the clinical teams. Second, to proactively examine the total costs of care and understand what those are going to be and prepare some strategies to reduce the risks. Those three things are going to show up in every kind of intervention that I will talk about next. And let's start with a couple examples. The first one is CABG. So listing pretty much in order of occurrence, these are the top complications that come out of CABG that induce a long ICU and length of stay. You've got atrial fibrillation, which starts right after the surgery, a sternal infection, stroke, pneumonia, and you can see even kidney injury is in this list, very common. But all of these are influenced by patient risks in advance too. Older people, which people can't help, but nevertheless is a factor. Pre-op diabetes is a significant indicator in all of those complications. If you have pre-op diabetes, you are more likely to develop any of the complications. Same with COPD, same with left atrial enlargement. It's a risk factor for AFib. And any pre-op AFib, of course, could throw you into an AFib after the surgery. So what are the strategies that you might use to mitigate the risks in CABG? All of them will involve both the clinical team and the hospital coming together to address issues that are systemic, that are procedure specific, and that are patient risk specific. Those three things, again, I'm working in threes again, are really important to know going into surgery. Essentially, what you're talking about is moving the time frame up for understanding where the patient is and trying to take mitigated clinical actions in order to prevent complications after as well. So assessing the patient risk in advance, a pre-op anesthesiologist patient virtual visit is an important thing, not on the operating table when the anesthesia agent and everything else is already decided and you're saying essentially, hi, have you had any problems before with anesthesia? And the patient is not exactly in a frame of mind to remember all those things. An agreed action plan customized to that patient on what will happen, and using evidence-based preventions when they're indicated. For example, beta blockers and other meds pre-surgery when that is advised by the clinical team, or a systemic multimodality infection program on the hospital side to prevent infections of all kinds. So let's look at lower extremity joint replacements. The extended length of stay and readmissions are caused by these top three: transfusion, DVTs, and pulmonary embolisms. And readmissions are specific to infection in the joint or in the incision and a choice of SNF versus home care. Now, for whatever reason, SNF is more predominant and lower extremity joint replacement, probably because stairs or some home environment. But it is a cost factor for joint replacements that isn't reflected in some of the other episodes. So what do you do to start to deal with some of these? For example, let's look at transfusions. Number one, this goes back to the issue of moving up the patient assessment and really understanding what that patient really has going into this episode. A prior assessment of anemia and supplementation of iron or other drugs when called for. It has to be a decision that is reached based on the clinical risk of that patient, which may not even be obvious under the current kind of process. A surgical and intraoperative, oops, I lost a no, intraoperative management, for example, patient blood management and salvaging blood, or the use of the patient's own blood instead of outside blood, which is safer for the patient, adoption of specific transfusion protocols, or using a different surgical approach that minimizes blood loss. All those are things that need to be considered specific to the procedure and discussed not just among the orthopedic team here, but also with the hospital, because the hospital also bears the risk of the cost for this. And everybody needs to really be on the same page for how this really affects the cost. Then there's post-surgical anemia treatment as well to be considered. So those are just some of the things. I'm sure there are others, but the issue is understanding what the patient has going in that is going to result in the particular common complication and planning for that as if it might happen in this one. Other strategies, this goes into the change of setting for SNF versus home care. It's evident in the joint replacement experience that not only are patients not readmitted as frequently from home as they are from SNF, but that the costs are much, much lower to begin with. So why don't patients go home? Well, because we haven't really talked about how we plan for patients to go home, how we arrange the environment or help the patient arrange for the environment and bring in other services. We leave it till too late in the process again. So if we can reduce the risk enough to perform surgery in an outpatient setting and to release the patient to home, those are things that we can do based on the risk of the patient and the planning for that as part of the surgical experience. As I mentioned, patients going to SNF is a higher cost situation. They're older, however, they have more comorbidities, they have functional limitations, they may not be able to navigate stairs, the house may not be able to accommodate a bed in the lower floor. And so it needs to be planned with the patient, but it needs to be planned. And that's part of the process that should go on very early and have the primary care physician involved too, not the specialist. I mean, a lot of the issues that we have on the physician side are the specialists focusing on the surgical experience, but not the surrounding issues. And like in primary care, we're going to need to expand that net. And whether that net means let's get the primary care involved, or let's get the ACO involved, or, what is the support mechanism for the specialists to deal with the aftercare of that patient? Right now, there is very little. Those are the two examples I want to focus on, just because I think they're illustrative of everything that can go wrong. And every one of the surgeries is going to have a common list of complications. That's where the costs arise, because they involve longer lengths of stay in the hospital. The hospital component is by far the most expensive component of the entire episode. You cannot change and reduce enough money just in moving from SNF to home care. You cannot change by even changing to the operating setting to outpatient versus inpatient. The only way to really save enough money to move the needle in team is to deal with complications. But moving up the patient risk assessment, working with PCPs to prepare and pre-treat patients pre-surgery or help accommodate the after-surgery component is a really important way. And one of the things the team does provide is a collaboration agreement with the primary care physician. So no longer is the surgeon under team simply kind of flying solo here. They are expected to communicate with the primary and work with the primary on those parts of the episode that occur outside their surgical window. On the systemic issues, this is the one that is probably the most thorny for those who are worried about the teamwork aspect, and I can understand that completely. The teamwork issue, however, because of the hospital risk and the physicians not being at risk, but also required to work with them in collaborative agreements, is going to be very much organized by whatever incentives the hospitals can provide to the physicians to also come to the table. And there is room in team for doing that. There is room for money to go to physicians, for support to go to physicians to address some of the issues so that everybody has the same kind of incentives going forward. And then the procedure-specific complications. It's no longer, for those who are worried about the CMS data coming out. Anytime we have a payment model, there is a light is going to shine on this data. And complications and which teams are doing well and which teams are not is not going to be a private matter. It will be available for people to look at. So it's important that the complications and these specific risk reductions are going forward in an environment where everybody sees the need to get involved. And this picture here just shows how complex it is. It doesn't have anything to do with cabbages or anything else. So what's your plan of action here? Team provides 3 years of historical claims data, but claims data is not where this is at. What you need is clinical data because, as you know, because I've been saying it many times during this presentation, the risks are all in advance. So you need to aggregate the clinical data that's coming out of the EHR and aggregate that with the CMS claims data to create team episodes that replicate what you'll be dealing with in the future. You can use those to collaboratively identify the historical cost issues, separate them, the causes into systemic, procedure, and patient kinds of risks, and address each of those components separately. The most important thing here, though, as you create episodes, is to honor the sensitivity of the data. Data is not perfect, and physicians need to be able to have a feedback loop on why things went amok. There are very many things that happen in surgery. A patient can come in an emergent situation. There's no time for an assessment. All sorts of things can be going wrong, and the provider really has no control over that. Or the provider may be specializing in the worst or the highest risk cases, and so the stats look extreme. And having that kind of feedback loop so that the surgeon and the anesthesiologist, because the anesthesiologist needs to also be held accountable for that part of the clinical team component, is important to do. Secondly, you need to create mock episodes out of your existing stuff. So as patients come in to your primary care practices, if you're a university or a large health system model and you have patients and they're going through a process which is going to end up in a joint replacement, you know who they are, and those should have a flag on them, and they should be entering a model in a pre-risk stage, just like you would be tracking patients with emerging prediabetes. So that's an important thing about episodes, is that even though the payment model, the CMS payment model, only addresses 30 days, a value-based care episode model should also be created that will cost and provide for a longer period of time so that you can see what's happening before the event. Cost variations get reflected in each of those, and so do patient risks. Out of those, there will be lists of complications and cost variations. You can see where they all are graphically, and they can be sorted by the type of surgery, by the type of provider, by the clinical team matchups, and so on. Those complications in the prior, using your 3-year test period, need to be prioritized and addressed, because you will see perhaps you differ from the model that is reported out there. Need to address those infections and various complications and build a consensus internally on the approaches that you have to mitigate. As I mentioned before, doing things in advance, serve it up here. This is a team sport, tennis. You need a better patient risk assessment to capture what's going on, and that needs to include a solid involvement of the primary care physician, a pre-visit with the anesthesiologist, could be virtual, patient strengthening if need be, and pre-treatment before any kind of surgery, and a post-surgical plan. That's important to have those things so that within that 30-day period, all you are dealing with are things that you didn't have the opportunity to mitigate. And then, of course, it goes without saying, you're going to find things where you need to really look at systemic issues and adopt protocols, especially in blood and infection. Those are the most common. Clinical pathways, maybe standardizing the approach to lower extremity joint replacements, producing evidence-based results on all of these, and helping the physicians with data identify where the costs are and where the opportunities lie for them as well. SNF and rehab protocols, who must go into a SNF, and if they're going into a SNF, what kind of SNF are they going into, and what will you require of that SNF in order to have an agreement under this process. And then, of course, as I mentioned, actual agreements with primary care physicians so that you have a common way for them to look at the data, a common communication mechanism, and everybody's held to the same standard out of team. Regardless of what kind of environment you create in terms of mitigating, you have to have a centered data platform to look at episodes so that everybody who is involved in the clinical team can see what those episodes are and what is happening with the patient. That should incorporate, as I mentioned, the clinical data from the EHR. Prior instances of hospitalization should be flagged. Prior cardiac instances, MI, for example, should be flagged. Episode details and log events. It goes without saying, although many don't look at it this way, the information that you gather on patients needs to be longitudinal. You're not looking at a 30-day span here to reduce the costs. You are looking at a very long pre-span and a very long after span to make sure that that patient isn't coming in as a redo as well. That redo isn't going to happen in 30 days, but you need to be able to capture that information because it's an important quality indicator of what happened the first time. There should be frequent updates and alerts for the clinical team and the PCP. The PCP should not be outside the process as the episode is occurring. And everybody needs to agree on the use of that technology and be participating in that technology, regardless of their ownership or employment relationship with the central body. This is extremely complex because specialties often have private groups. PCPs may be outside the system. And so this will depend on some kind of middleware or platform that everybody can see this information throughout the process. We have this kind of technology already. We've been building this for years because we have chronic disease episodes, procedure episodes. We operate for clients on the oncology payment model from CMS, and we are starting the kidney model as well. It's important to be able to have a platform that has the technology and the data from people who are experienced. And so I just want you to know we're out there to help you. So that really wraps up um, the detail of what I wanted to present. And here's another polling question. I'd just like to know where you are in your actual development for team and whether we can help you.
All
So
right, you've seen it on your screen here. Sorry, Terry. Where are you in your development for team? Are you starting out but would love to hear more, kind of in the exploratory early phase? Curious. Are you definitely interested? And this is the track that you're wanting to go, and maybe you just need a little direction or help to get there, or this isn't for us. You know, this isn't something that we're engaged in right now. And we'll give this, and again, this is anonymous. We're going to show you guys the results here momentarily, and you'll kind of see. And I think you'll be interested to see what other folks are saying in your position. And I'm going to give it maybe another 10 seconds or so for the results to come in. And again, where are you in your team
this
or in
helps
your
me measure
development?
my persuasive powers.
I'm sorry?
This helps me measure whether I delivered my message that I wanted to, which is the ways to reduce costs and team.
Yeah, that's right. Yeah, there's a lot here. I mean, obviously, there's a ton of material to cover. And all right, I think most of the results have come in. I'm going to go ahead and share the results here. All right, so Terry, we've got 33% of the audience is starting out. Would love to hear more, is curious to learn. 44% are definitely interested. And that's great. You know, this is definitely on the right track, and you were in the right place in this webinar. And with Terry at the blackboard, because she is definitely an expert in this stuff. So and then 22% said this isn't for me, and that's all right. We've got plenty of folks that are just wanting to learn. So I'm going to close this back out and turn it back over to you, Terry, to close out.
Okay. And I'm ready for questions, Garrett.
Yes, and let's see. Now we'll come back on here. And all right, now if you do have a question that you would like to ask at this point, go ahead and use your control module. There's a space specifically for questions for you to ask there, and we're going to get to as many as we can. First question is this. You talked a lot about the clinical team. What do you mean by that? What do you mean by that, and why? What do you mean by that, and why would it matter if hospitals are at risk and not physicians? Easy for me to say.
Yeah, that's a very good question. The clinical team is going to be, let's take a particular, well, any surgery is going to have at least three members of that team. They're going to be the proceduralist for the specialties, so the cardiovascular surgeon or the orthopedic and neurosurgeon or the gastroenterology surgeon. And then there will always be an anesthesiologist on that team, and there will always be a respiratory therapist on that team, and there could be other clinical members of that team, depending on those who might be on call during the surgery. If it's a particular case where the patient has a lot of risk factors, another specialty may be waiting to be called, and that person will also be on the clinical team, and the primary care physician should be on that clinical team. And why should they care? Because, um, well, what are the incentives of hospitals if you lose money for them? I think that's the question. Um, Hospitals have really been very favorable in and really helped physicians a lot based on revenues brought in by the physicians, because that's revenues for the hospitals as well. But once you start costing them money on the negative side, then it's a different equation. And you may see a lot of those benefits disappear, or there may be incentives. If you're an employed physician or an employed specialist, I have no doubt that this would work its way down into the compensation agreements. If you're not an employed physician, then you're really hurting your own practice as well as hurting the hospital. And because this data will be public, and you will find that you won't be able to get commercial business as well either. So your centers of excellence for heart and orthopedics and all of those things will suffer if physicians don't get involved and perceive this to be hospital risk, not my problem.
Gotcha. Okay. Next question here is, do you see team as a payment model that's going to expand into other areas in the future?
Absolutely. Absolutely. I see episode payments in general expanding because they're going to be CMS is trying to cut money. And so if they simply continue to pay fee for service, and they've said this, I don't have to say it a lot, but if it's continued to be fee for service, the costs go up and they have no levers to reduce it. So I think this is their first lever on the procedural side. The bundled payments worked a little bit, but not much. And that was a problem because they didn't save money, and they covered a lot more territory. But the structure of the bundled payments was different, and it wasn't as tight as this payment model. I think they've given a lot of thought into this, and it is likely to grow and be the model for proceduralist kinds of things. Um, on the treatment side, I think EOM is a treatment model type that is likely to expand. And the new ASM, which is a condition-based specialty model, when we see how that goes forward, that is going to be a significant. I mean, it's starting out with two big ones, low back pain and heart failure. And I'll be doing another webinar on that, especially after CMS finalizes the rule on that. But that is another one. That's another answer to the major conditions that are dealt with by specialists. Specialists are 40 to 60% of total healthcare costs, and probably more than that because it's really hard to estimate. And so those numbers are rough. 20 to 40 is even too big a window. But to the extent that specialists are really driving not only the hospital expenses, but the patient future, yeah, I think this is going to be really big and expand a lot.
Very good. Next question here is, how can we streamline team efforts within our practices to ensure a decrease in hospitalizations?
Well, as I have said, first of all, you need to look at your data in the past so that you know what you're likely to get. And secondly, it's not just a practice that can do this, but you can identify these processes that you have to have on the physician side. So making sure that everybody has a primary, you know who they are, creating a network of those primaries so that you have agreements with them on what they're going to cover and what you will cover is an important thing. Deciding, for example, if you're an orthopedist, that DVTs will not be covered by the primary but be covered by somebody else clinically is an important thing, because the primaries, I can tell you, don't have an answer for that all the time. So it's an important thing to address the complications before and after through collaborative agreements, and then figure out your processes within the practice of getting as much information prior to the surgery as possible Now, some of these surgeries are emergent. The hip fracture repair, hard to imagine that that's going to give you a lot of lead time. Um, that doesn't. So you're going to be depending on having that information there that's at the moment of. On the other situations, however, there usually is some time for you to be able to gather that information, and that's the way you can mitigate it.
Wonderful. Well, that is actually all the questions that we have today. I think folks are trying to absorb all this. And there's about 3 webinars wrapped up into one in this material here. So I think it's okay if we end a little bit early. But I wanted to, as we do that though, I wanted to encourage you all to head over to vbcexhibithall.com and check out the virtual exhibit booth for Roji Health Intelligence. In there, what you're going to see is, or be able to kind of dive into them and what they're doing in the space. Yeah, familiarize yourself, educate yourself on some of their services. As you can see, Terry is definitely a subject matter expert in this space, and she is can be trusted to guide you in the right way. So feel free to reach out to her there. Also on bbcexhibithall.com, by the way, is where we're going to archive this webinar from today, and we are going to send out a link to everyone that you'll be able to access the webinar and download the slides. But you can also find it along with all of Roji's other informational webinars in our library there. And then finally, if you wanted to reach out to Terry directly, you can do so here. Let's see, there we go. Her information, and Dave Halpert, who's also done some webinars with us, who's the chief of client team, his information is there as well. And feel free to reach out to them directly, or I'm happy to facilitate an introduction for you as well if you wanted to contact me. But thank you all again so much for joining us and spending your afternoon with us. And we'll let you know about part 2 when that comes out. We'll definitely make sure that we send you that information so we can get you registered. Thank you and have a wonderful rest of your afternoon. Bye bye.
Thanks, everybody.